welcome to Series 211 of the Africa Healthcare Network Fireside Chats. My name is Dr. Amar Swali. I'm a consultant nephrologist and physician working as the Director of Clinical Operations for Africa Healthcare Network in Dar es Salaam, based in Dar es Salaam. And it is my absolute pleasure to introduce the speakers for tonight, starting with someone who is an absolute legend in Tanzania, and that is Professor Larry Akoko. Prof. Akoko is a surgical oncologist and a professor of surgery at the Muhimbili University of Health and Allied Sciences, MUHAS. He completed his MD at the University of Dar es Salaam and then his Masters of Medicine in Surgery, General Surgery in MUHAS. And then he went on to complete the prestigious Surgical Oncology Fellowship Program at the Ernest Borgstein University Tata Cancer Hospital in Mumbai, India. He returned to MUHAS as a clinical professor and has served in many institutional and national leadership roles, such as the Tanzania Surgical Association, the Medical Council of Tanzania, and Prof. Akoko has been a faculty lead at the University of California, San Francisco Center for Health, Equity, Surgery and Anesthesia, CHESA, for several years. He's helped mentor young researchers in Tanzania through the UCSF grants. Prof. Akoko has mentored several surgical residents from UCSF, including Dr. Soumya, who I'm going to introduce very soon, and has been both a trainee and now an instructor in the arteriovenous fistula, AV fistula, vascular skills training sessions. Prof. Akoko has been instrumental in the piloting of training and hopes to expand these skills to general surgeons across Tanzania to improve hemodialysis access. It is also my pleasure to introduce Dr. Stephanie Lin. Dr. Lin is a US board certified vascular surgeon at the Marin General Hospital and an associate clinical professor of surgery at the University of California, San Francisco, UCSF. She completed her medical school at the Stanford University and general surgery residency at UCSF. She then completed her vascular surgery fellowship at the New York Presbyterian, University Hospitals of Cornell and Columbia. She is a faculty member of the UCSF Center for Health Equity in Surgery and Anesthesia, CHESA, for the past several years, and she's helped mentor young researchers to develop international programming. For more than 10 years, she has organized teams and supplies going almost yearly to Guatemala, Philippines, Solomon Islands, and Uganda and Tanzania. And additionally, she has been an active board of trustees member for the Hospital de la Familia Foundation, including spearheading the establishment of a laparoscopic videoscopic program last year at the namesake medical facility in the rural highlands of Northwest Guatemala. Dr. Lin has led and trained several general surgeons in vascular surgical skills in collaboration with MUHAS for the last 5 years throughout Tanzania. And that brings me to our first speaker for the night. Dr. Soumya Mangipudi is a fourth-year integrated vascular surgery resident physician at the University of California, San Francisco. She is a current U.S. NIH Fogarty 2025-2026 fellow and is performing research regarding the risk stratification of diabetic foot ulcers in Dar es Salaam through partnership with MUHAS for the year. In addition to her research, Dr. Mangipudi has helped coordinate the AV fistula training sessions around Tanzania in conjunction with Dr. Lin and Professor Akoko. Dr. Mangipudi went to medical school in Washington, D.C. at the George Washington University School of Medicine. She completed her master's in global health and surgery at King's College London. Her passion for global health started during her undergraduate studies, and she hopes to pursue an academic surgical career to improve access to high-quality vascular surgery care in a lower resource setting domestically and internationally. This trio of speakers tonight is going to be speaking to us about hemodialysis vascular access, building capacity to implement Fistula First initiative across Tanzania. So Dr. Soumya, over to you. Welcome.
Great, thank you so much. Are you able to share the slides, Dr. Swali, or otherwise I can do so? Thank you, perfect. Sorry for the background noise. I'm unfortunately in kind of a busy area right now. Thank you all so much for coming to this webinar. We're here to discuss hemodialysis vascular access and specifically building capacity to implement Fistula First initiative across Tanzania. We'll go into a little more depth. Dr. Swali has already done an excellent job introducing us. Thank you so much for the kind introduction. So this is our agenda for the evening. We're going to start by introducing the team and the mission, talk about what the current hemodialysis environment is in Tanzania and specifically the access aspect. We'll talk about some of the challenges and opportunities in the access landscape. And then we'll follow that by discussing why a Fistula First model and also what does that mean in the context of Tanzania. And next, we'll discuss surgical capacity building efforts that are being underway, and by talking about what expansion looks like and what the future may. So we've already talked about Dr. Lynn, who has been an amazing addition to this team. She's been coming to Tanzania for the last 5 years or so on behalf of UCSF and CHESA, which is our International Global Surgery Initiative at UCSF. And she has really been instrumental in helping train people directly in surgical skills, but also has a lot of experience in some of the other tools and materials we need to make that happen. I'm a recent addition to the team. I came here as a Fogarty Fellow and sort of picked up the project where it left off. Started a few years ago. And my focus is in vascular surgery and personal context. In the US, you can match directly to the vascular surgery residencies. So instead of doing all of general surgery and fellowship, I'm sort of on a faster path towards that. My goal really is to help improve the excellent work that's already being done by other people who are not mentioned on the slide. Dr. Nathan Brand, Dr. Bill Schechter, who's from CSF, Dr. Akia, who's part of the team as well. So we're trying to bring all that to fruition. Dr. Larry Akoko and Dr. Mwanga, who I don't believe is with us tonight, they are part of the general surgery department at MUHAS. We also have urologists on the team and are working with some of our CT vascular colleagues. But we are really fortunate to have a home at MUHAS, and the passion that Dr. Akoko has shown to really get this product off the ground is amazing and unusual for a surgical oncologist, but he really believes in the mission, so I'm lucky to work with him. And then recently, and how this webinar kind of came about is we were lucky to work with the African Health Network on our most recent mission, which was at Cardinal Hospital, close to the airport in Dar es Salaam. And through that work, we sort of learned more about the AHN's mission and begin discussing what the future looks like for us all to be on a team together. So that's what we'll talk about towards the end. So what is our mission? We are obviously coming from very different backgrounds, and we all have a different stake in what this looks like overall, but I would say it's multifaceted. First, the goal is to increase prevalence of AV fistula use. Just from observation and from some initial data from AHN, we know that there are a lot of people who could be having AV fistulas dialyzed through, but are otherwise on temporary access. The next thing, which ties into that, is surgical capacity. It's actually being able to equip surgeons with the skills and the knowledge both about preoperative and postoperative assessment, in addition to the intraoperative technical skills to make AV fistula surgery possible. But more than that, to have successful long-term AV fistulas that people can dialyze through and avoid infection and multiple catheters, et cetera. An internal goal is to assess our education model. So we'll talk more about that, but we have a didactic session, we have a simulation skills session, we have the practicum. We actually operate in the hospital with real patients. So we also want to make sure that this educational model is effective, and that's one of the things that we will be hopefully partnering with AHN with to study that in a rigorous way and to show that our outcomes are just as good as what's being done, but also hopefully just as good as what really benefits patients. And then last but not least, one of our missions is to decrease catheter-related morbidity and mortality. All of you work in this field, and whether it's coming from a nephrology perspective or any other perspective, we all see what it takes to keep a catheter sterile and clean is incredibly difficult. We know that there are lots of risks and other complications that come with that. And so, our hope is through this long-term mission, we can sort of improve the morbidity and mortality that we're seeing for people with catheters. And while fistula isn't a guarantee that there won't be any problems in the future, a lot of the data we'll present will hopefully talk about what we can do to reduce those numbers. Thank you. I'll turn it over to Dr.
Thank you, Soumya, for the introduction. And the team has done great work. There will always be upsides, and opportunities will always be abundant ahead. So I'll take you through current HD access environment in Tanzania and the challenges and opportunities that we have ahead of us. So this is a map of Tanzania, and on the left side of the screen you can see AHN dialysis hemodialysis access centers, which are 21 in total across Tanzania. But on the right-hand side of the screen, you can see the medical facilities in Tanzania, where we have got 23 clinics and 47 hemodialysis units in total across the country, both from private and government facilities. Almost all the 32 government regional hospitals are offering hemodialysis across the country. And the remaining mostly are either faith-based or private facilities. So there are 23 standalone clinics, which means patients with hemodialysis are increasing daily. And we are embarking on another different study with another different group on how to transition these patients into transplant as well, so that we provide some durable solution to this patient. But currently, this is the landscape of hemodialysis. So having a total of 70 units offering hemodialysis of different capacities, some with 8 beds, some with 40, some working 24 hours. So the numbers might not reflect the exact number of patients, but most of these units work 24/7 around the clock. So again, there's been progress in CKD care and integration of adult and childhood nephrology services in Tanzania, as you can see by a paper written by Furia. So Francis Furia is basically a pediatrician. And so we did not have pediatric nephrology, so he was forced to do adult nephrology first. And then later did a fellowship in pediatric nephrology in Cape Town, South Africa. So he runs both clinics, but he runs the only pediatric dialysis clinic in Tanzania. So as I said earlier, hemodialysis is offered across many institutions, and we have a total of 649 hemodialysis machines in the country, and a total of 3,231 patients are currently on hemodialysis. So number of patients on home hemodialysis is 0, so all of them have to come to a facility. The average duration of dialysis is 4 hours. The number of dialysis sessions per week in Tanzania currently is between 1 to 2. And vascular access for hemodialysis therapy, all patients start hemodialysis in temporary access. Approximately 40% have AVF, but rest have temporary catheters. So the cost of hemodialysis session is between 80 to 120 US dollar, depending on where you're getting it. And dialysis funding, while 90% of hemodialysis patients are NHIF, while NHIF only covers 4% of the population. So you can feel that the majority of the patients cannot afford hemodialysis because they can't afford it. Only 10% are paying out of pocket or are privately insured. And personnel who run these centers are largely nurses. So out of the 3,231, 1,000, close to 2,000 patients are on temporary catheters up to now. This highlights the need for AV fistula creation in Tanzania. So at MUHAS by 2024, 25% of patients were non-tunneled central venous catheters, while 40% only were tunneled and 35% had AV fistula. So of those that had non-tunneled, average time of changing was 7 months, and 69% of patients had multiple insertions, commonly due to dislodgement, infection, or a thrombus blocking the flow altogether. And so this raised concern among most of us to want to find a permanent solution to this usage of non-tunneled central venous catheters. What are the challenges that we face on daily basis? Next. Yeah, so catheter-related bloodstream infections are common. Patients normally come with sepsis, and some of them lose their life through sepsis. Catheter dysfunction is also a common problem, but also the healthcare utilization costs, frequent changes, the dressing needs, the admissions due to infection, the antibiotics. I have even amputated limbs because of catheter-related problems with infection and limb loss. overwhelming infection that necessitates limb loss. So there are many opportunities, many challenges that currently exist, and all this provide us an opportunity to come in to try and see how to have all our patients on a permanent vascular access, because dialysis patients stay longer on dialysis. They don't transition that faster into transplant, which is not routinely available across the country. So, for example, at Kilimanjaro Christian Medical Center over 2 years, they reported 56.6% of patients with non-tunneled central venous catheters developing bacterial infection, and 90% were gram positive. That only resolved with vancomycin. So this is even challenging. Gram negatives were most effectively covered by meropenem, which is more costly, and the most common factors associated with infection were femoral lines, patients being diabetes, and patients with hypoalbuminemia. Multiple dislodgement, risk of bleeding, multiple placements, higher rates of central venous stenosis, making future AVF fistulas less likely. When you assess these patients for central venous, for AV fistula, you might think you are getting very nicely bigger veins, nice for fistula. But some of them are bigger because they are already blocked proximally due to repeated catheterization and repeated access risk anatomic injury. Most recently, we had to repair a femoral catheter that had gone through the artery, and patient came profusely bleeding in a peripheral hospital. And lucky enough, it was during our camp, and this was the first case they experienced, and we managed to save this patient. Catheter wear and tear, breakage and clogging, and uncomfortable and require care with sterile dressings almost on daily or fortnight basis, and this added costs to the patients. Next. So disruptions to hemodialysis due to catheter removals and replacements. Some patients have completely run out of option. Catheters on the left, right, femoral left, right, and all blocked, and now they're out of options. But sometimes also delay in procuring the next catheter for another suitable access. So higher blood pressure, volume overload, respiratory complications, leading to admissions, which are all leading to higher cost. Each procedure to place a central venous catheter costs between $170 to $260 US, and the catheter alone costs $50 in Tanzania. And 2 to 5 catheters per year plus procedure, that would go to 1,300 or 3.4 million Tanzanian shillings per year, which is a lot. While some costs are covered by the biggest insurer, which has the largest number of patients, but complications might not be covered by the insurer, and this sends the costs directly to patients who are already overwhelmed by this chronic type of care that they are receiving. Yeah, so those are the challenges, and amidst those challenges rose the opportunity to want to talk about a fistula first model that I will now leave to Stephanie Lynn to take us through.
So what is a fistula first model? Well, it really means creating or the patient having a fistula in place prior to the start of dialysis initiation. And an AV fistula, as we know, typically needs a minimum of 6 weeks to be ready for use for dialysis. So really what a fistula first model means is that we need to try and identify these chronic kidney disease patients in clinic before they need to start dialysis and refer them early to a surgeon. The result of that would be to limit the time required for a central venous catheter. And the ideal would be less than 3 weeks if possible, or at least the time, for fistula maturation. So maybe 6 weeks or 8 weeks, something like that. Fistula first historically has been the ideal way to go for hemodialysis, which is why we really need to partner with you, the nephrologists and the kidney care community, because early nephrology care really is essential for this. And this is kind of separating out peritoneal dialysis, which is really very rarely used in low middle income countries. So again, we all know that fistulas have a much lower incidence of complications compared to central venous catheters. And in particular, the one that's most significant is the infection risk. The use of AV fistulas reduces the risk of infection, a relative risk reduction of more than 90% compared to central venous catheters. The risk of infection with central venous catheters is incredibly high. Catheters have a 7-time higher risk of bacteremia and a 2-time higher risk of sepsis, which is the most common cause of mortality within the first 6 months of initiating dialysis. And that risk of infection is higher for non-tunneled catheters compared to tunnel catheters. Other features of fistula compared to central venous catheters that are better for fistulas than catheters is a high rate of blood flow, dialysis adequacy, thrombosis, central venous stenosis, and durability. Really, the main thing that catheters are better for than fistulas is the ability to use the catheter immediately. Again, going back to the fact that we need to partner together with the pre-operative and early kidney disease management and care of these patients. Notably, so going back to what I was saying about the fact that many of these patients do die within the first year of starting dialysis, 1/3 of those deaths are related to sepsis and 1/3 are cardiovascular. So what are the roadblocks to a Fistula First initiative? Well, one of the big ones, as we've seen in a lot of our camps, is financial. Working with the NHIF, thank you, Dr. Akoko, versus patients having to pay for themselves. The median annual cost for hemodialysis in Africa is about $19,000 US, which in Tanzania equates to more than 46 million T shillings, which is a lot of money for patients. They have competing needs, trying to decide between paying for dialysis sessions 3 days a week or versus their other medications, perhaps for hypertension or diabetes, paying for the catheters if they need to be exchanged frequently, or antibiotics if they get a catheter infection. As a result, we know that 84% of patients actually discontinue dialysis within the first year. And of course, almost 100% of those patients will die. Another roadblock to having AV fistulas as the first dialysis modality is geography. We know that most dialysis units, as well as access to surgeons and other specialist care, including nephrology, tends to be more centralized in the urban areas versus the remote areas. Surgeon ability, training, and time is another factor. We were talking recently about how in areas where surgeon availability is much easier, the AV fistula rate at the local dialysis units can be up to or more than 70%, whereas in areas where there is very limited access or availability of surgeons, that rate of fistula prevalence can be as low as 10% or 15%. Patient anatomy is something that I've noticed in doing these camps. That is an issue in trying to make AV fistulas. The veins tend to be very small. It's possible that they've been cannulated a lot for blood draws or various other things, or perhaps related to the underlying disease process. One of the things that we're trying to include and teach and try and promote is the use of ultrasound vein mapping preoperatively in order to try and best select those patients who will have a successful fistula. And another sort of issue related to Fistula First initiatives is the durability and sustainability of creating these fistulas. Ideally, fistulas do need to be monitored. There is a maintenance process long-term in order to keep them functioning for as long as possible, as well as possible. And this is one of the sort of debates, or not really a debate, but issues between having surgical camps that really are just focused on service orientation, meaning providing a surgical service, just getting those fistulas made for those patients, versus kind of what we've been trying to focus on is an education-oriented camp where not only are we trying to educate the patients, but also the staff, local surgeons in how to do these operations, how to think about creating fistulas and how to best maintain them and keep them functioning. I'll just mention as an aside, the Fistula First initiative was started in 2003 in the US with the initial goal of a 40% prevalence of AV fistulas. Later in 2009, that goal was increased to 66% because there was such a response, a positive response to trying to push for fistulas first. However, around 2019, I think people started to realize that AV fistulas really are not for everyone. And so it has shifted a little bit in the US towards a more patient-centered approach, meaning, if patients have a very short life expectancy or have very difficult veins, it may not be worth putting them through an AV fistula and the different things that may be required to get that fistula working, in which case converting to a tunneled catheter or leaving a patient as a tunneled catheter patient, or perhaps trying to use a prosthetic access might be more appropriate for those patients. And I think the question, thinking about this overall globally in terms of trying to promote a Fistula First initiative is this sort of patient-centered approach applicable in Africa where resources may be limited? And I would argue that it is still applicable. We do want to try and maximize the outcomes for these dialysis access in these patients. And we also want to use our resources efficiently in Africa. So that's something just to keep in mind as we're going through this and trying to really make this a sustainable program. Okay, so next we'll talk about, I'll just sort of explain to you what we've been doing in the last few years and how we think about it. So in trying to build the capacity for surgeons to do more and provide more AV fistula surgery for dialysis patients, we really went about it, number one, thinking about it in a way that we were trying to be very strategic about what training we were providing, and also in how best to share the task of creating dialysis access. We thought about decentralizing access surgery so that it doesn't require referral to one of the major urban teaching hospitals, which reduces the travel burden both on patients and on surgeons going out to remote areas, and helps to redistribute the work more reasonably from just the 2 or 3 surgeons in the country who have the experience to do AV fistulas, and redistributing that out to general and other surgeons who have the same technical skills. They just need to have a little bit of guidance and training on how to apply them for this particular purpose. And then the third part of what our program was trying to incorporate was electronic-based learning, both for the trainees and the trainers, to provide mentorship as well as knowledge transfer. So we've done about 3 full AV fistula training camps. The first was done at MNH in Dar, and then another in sort of split between actually Amana Regional Referral Hospital and in Dar and Zanzibar. And then most recently we started a program in Rugambwa, and I'll kind of leave Dodoma as a separate thing because that was a little bit of a different concept. We've had at least 4 surgeons who've received the full training, which is really 2 separate 1-week surgical camps, and 3 that have done at least 1 week of those 2. It starts with a didactic curriculum as well as skills lab training sessions, both on dry lab, meaning rubber Penrose tubing and sutures, as well as an animal model where we've used the esophagus and trachea of chicken necks to simulate both the artery and the vein for an anastomosis. I really, in my experience having done these, I feel like looking back over everything, the goal really should be for each trainee to participate in 30 operations, 30 dialysis access operations. The first third or so, 5 to 7, or maybe quarter of those cases is where that surgeon is acting as the first assistant. And the rest really is where gradually over each iteration, that surgeon should be taking over more and more of that case as the primary surgeon, to the point where they are actually making most of the decisions and doing the majority of the case. Right now, ongoing, we're trying to evaluate the program and how well it does transfer those skills, the impact that it makes on patient care, both for dialysis access, but also, the fact that all of these vascular skills are very applicable in other surgical specialties, whether it's trauma, surgical oncology, urology. I mean, these are useful skills for surgeons to have, regardless of whether dialysis access is a big part of their practice or just a small part of their practice. At present, the way we've been doing it, we are bringing a lot of the consumables with us to these trainings. We're bringing surgical instruments, portable ultrasound, and of course, the trainer surgeons. So who are our trainees? Our trainees are urologists, they're general surgeons, they can be plastic surgeons, and of course, we are also trying to make sure that we include our residents in Africa in these trainings, because the idea is to teach the teachers. Eventually the residents will become attendings, and hopefully they can maintain and spread these skills so that it's more readily available. So what are the challenges for capacity building? Well, again, finances is an issue both for the patient, the government. We struggle to find sustainable funding sources to help us in our efforts. For the surgeon trainers, we've been really lucky to partner with MUHAS and where we have had a unified vision in terms of our goals, particularly with Dr. Akoko. Again, I'll mention Dodoma as a place that I did do a training session last year. They do have a different sort of mindset about how to do training. But really, what I've experienced in all of this is that the surgeon trainers are a limited resource. And so we need to try and build that resource as well as the surgeon trainees, where limitations are in their availability and their interest. When we ask them to do this training, they are taking time out of their day-to-day jobs and making their own income in order to spend the time with us to learn these skills. Their own job stability and mobility has been an issue. One of our trainees finished our training and looked to be excited to be able to provide that service to the dialysis patients that were based at his regional hospital. But he then got transferred by the government to another hospital in the south of Tanzania, where there is no dialysis unit there. So things like that were unexpected issues, but something that we'll just need to continue to work through. Other challenges for our trainees is figuring out how to measure competency consistently and equitably, as well as what to do in terms of credentialing. How to make sure that surgeons who train are recognized as having had that training and having that skill set now. Maintenance of skills is a longer term issue that does concern me as a teacher. We want to make sure that these surgeons continue to select cases appropriately, that they are planning their operation and executing it. And that's where continuing mentorship is really, really important, and where we continue to interact with our trainees via WhatsApp or whatever means is easiest for them. Another thing that I learned along the way, and that I'm really excited because AHN has a really big emphasis on this, is nursing education. The nurses at these dialysis units do need to know how to cannulate fistulas, because when they're used to using catheters all the time, there is a skill associated with the care and management and cannulation of fistulas, both how to make sure it's sterile, the techniques that are used, how to recognize when there's a problem. So I think nursing education is super important, and I'm really glad to be partnering with AHN on that. Lastly, another challenge is quality assurance and oversight. How to make sure that the fistulas that are being created out there are good, that we're not just doing these operations and then they fail, and then we're just doing more and more operations and using up our limited vein resources for the patients. In this point, data collection and critical review of that data and our outcomes is really important, and so we're working on that as well. So finally, the next steps is again, this partnership with AHN and how we're going to expand this hopefully in the future. So overall, our goals are to improve patient engagement and education. And I know AHN is really good at that. I was really impressed with the posters and things that I saw in the dialysis unit, educating patients about what to look for, what they should be seeing, what their fistulas are, and how they work. We would like to try and develop a partnership with NHIF so that more of the dialysis care or kidney care expenses are covered. This will ultimately lead to better care and outcomes. Streamlining the supply chain is super important. And in order to do that, part of that is partnering with local surgeons, which is their own supply, to increase availability and extend fistula durability. Expanding this type of training program regionally throughout Tanzania, as well as perhaps, the rest of Africa, if possible, I think would be really important. I know, some areas are trying to develop vascular fellowship training programs, which I think is a great idea, but it's a much longer term view, and these needs are existing now. And so I think this program is a way to try and target the current existing needs of the patients. Studying our model, again, via education and outcomes research, looking at fistula patency rates and complication rates will help provide better care and help us understand better how to do this training, how it will work best, what we need to do to make those skills transfers applicable and durable and sustainable. Lastly, long-term, of course, using prosthetic grafts, ideally would be great because, like I said, not all the veins in the patients are usable for fistulas. Concerns for that, of course, are infection, as well as long-term maintenance, which typically requires an endovascular type of care. So the availability of interventional radiology to be able to do those types of procedures will be important to develop and to grow, which I know is also happening kind of in parallel with what we're doing. And then lastly, the availability of kidney transplants. Other partners at UCSF through CHESA, our kidney transplant colleagues are working with the transplant surgeons in Tanzania, as well as the rest of Africa, to try and improve the availability of kidney transplants for dialysis patients. Thank you very much for your attention. We're really excited to work with you, and I hope we can provide some valuable service to you and your patients now and in the future.
Thank you very much. And I would just like to acknowledge that this initiative, it's a blueprint for restoring safety and sustainability, to the hemodialysis care that we offer in this country, and might add also restoring dignity into it. And as already identified, vascular access has been one of the greatest limiting steps in the country, and the over-reliance on the temporary catheters that you see. It also reflects the shortage of trained hands that we actually need. But this initiative again demonstrates that it's not going to be a permanent gap in the future. I would like to extend my sincere gratitude to Prof. Akoko, Dr. Lin, Dr. Soumya, for leading this, from the front by training the surgeons, but also building the confidence and more importantly, encouraging local ownership for our surgeons here. I personally hope that Cardinal Rugamba was just a starting point, and the Fistula First initiative in Tanzania will succeed because now we will have people who have been empowered to carry this forward. So thank you so much for that and leading this charge. And I would like to take this opportunity to invite questions for our speakers. You could raise your hand and we could unmute you. You could put your question in the chat box.
Dr. Lin, thank you very much. Professor Akoko, thank you very much for the wonderful session. Very educative, and thanks for all the work that you're doing, as well as Soumya. One quick question. So from your current experience, what do you think the projections could be from what you've seen so far in terms of training?
Projections for, what do you mean by that?
How many surgeons do you think we will be able to train, and what could be the outcomes that we could project from the very limited, of course, exposure that is there right now? A few surgeons you've trained, but some sort of an idea that has formed now from this?
I don't know if Dr. Akoko has a different opinion, but I personally think if we can identify 2 surgeons at the various different, regional locations, say, those 2 surgeons can work together to do these cases. And they would be able to serve and take care of all of the dialysis patients in that area. You don't need 100 surgeons to be able to do dialysis access, for 1,900 patients. You probably need, I don't know, 20 or something like that but they need to be located in the right areas so that they are closer to, anyway, where a lot of those populations are. I think we've talked about how difficult it is for patients who live many hundreds of kilometers away to travel to a place to have surgery, and then go home. So the closer we can get to where the patients are and have surgeons who can provide the service skillfully and reliably, I think would be great. I definitely think it's possible to have enough surgeons trained to service all the dialysis patients that are in Tanzania. It may take some time, it does take time, but you have the patient population, and we're definitely committed. So I think, at least from my perspective, it's about identifying the surgeons who are willing to do it.
Yeah, thank you very much. That's very heartening, actually.
If I may also ask a question, and any of you can choose to answer that. And I think the biggest challenge I feel, are the breakdowns that we face in the ecosystem. A lot of these people come to us very late. The vein preservation is very poor due to the repeated punctures that they undergo, and sometimes there are even underutilized fistulas despite the creation. So my question is around the sustainability over the how do you think we could translate this into like a sort of a national catheter reduction program over the next 5 or 10 years? I know it's a difficult question. I'm sorry, but I had to.
I'm going to start with one brief answer, and then I'm going to defer to Dr. Akoko to talk about a national program. But I do think there is a patient education that really needs to happen, because I've had several patients where we made a fistula, but the patient was afraid to use it. They thought that the catheter was more reliable, no needles, so there wasn't any pain associated with it. So from a utilization and sustainability issue, I do think patient education needs to start early, and it needs to happen to the patient, to their family members, really explaining the benefits of fistulas over catheters. And then I'll defer to Dr. Akoko how he thinks a national program might be developed.
You left the most difficult one.
Yes.
So the idea, if we have to go with a catheter-first approach, as you said earlier, Dr. Lin, is we need to have the right people at the right place. It cannot depend on a helicopter type of heavy fistula access. And that's the very reason why we chose a training model over service, so that we identify surgeons affiliated to facilities offering hemodialysis. If at least we can have one per region to start with, at least 2 surgeons per region, or in a vascular access clinic, or region, whether it's a regional hospital, but within the region, so that it's closer to the patients where they're getting their dialysis. I think that would be wonderful. So my vision is to have residents train, because they'll finally work in the regions, but in the meantime also identify surgeons in the regions. So like, for instance, when you go to Tosamaganga, the focus should not be just offering surgery. We should identify a surgeon that will use the patients at Tosamaganga to train. So maybe Tosamaganga will only need 2 visits, and then that serves Iringa as a region. And it can serve the neighboring regions in the meantime, like Njombe. Because every time you do every fistula here, patients will come from Arusha to Dar es Salaam, and there'll be an inconvenience to be continuing their dialysis because they're trying to force themselves into another dialysis unit where they were not scheduled to appear. So the idea is to focus and have steadfast training and have surgeons with interest in training. But I was wondering whether patients coming early or late, but they are chronically ill patients, And I think the idea that one day I might need dialysis is not with patients and it's not with doctors. So there are multiple difficulties with cannulation. And so finally, this will have difficulties with vessels in the future. I don't know whether it is time to introduce a dialysis arm so that all providers know that one arm must not get heavy cannulations unnecessary unless it's life-saving, so that it is saved for dialysis. That will translate into, in the long run, maybe it will take 20 years, so that we have a population with an arm that has never been cannulated, especially for the chronically sick patients, to save one arm just for dialysis. I don't know whether that's working elsewhere, but I'm looking at our patients with the blind cannulations, difficult cannulations, thrombophlebitis. They stay with catheters with the cannulas for longer times, the normal cannulas. So you get thrombosed veins and things like that. So whether we can provide proper education on cannulation, how to take care of cannulas, which limb to cannulate, that would also help in the future, not in the immediate future, but in the long run.
Thank you, Dr. Lin. Thank you, Prof. Akoko. Dr. Lin, you've answered one question on the chat, but I would love for you to take it live. And the question is from Dr. Huda Akrabi from the Northern Zone. What is the rate of primary AVF failure in your experience in general?
I was trying to explain that there are, it depends how you want to define failure, because there is a known failure to mature, meaning you create the fistula and it doesn't grow big enough or for the dialysis nurses to access, to cannulate. That is a known issue, and that is something that really relates to the condition of the vein at the time, before surgery. And goes to what Dr. Akoko was saying about saving an arm, saving veins for dialysis access in advance of thinking that they need dialysis. So that known rate of failure to mature can be pretty high or relatively high, 25%, sometimes 30%, depends on the patient, their age, other comorbidities and things like that. That usually can be mitigated by a secondary procedure, depending on where you think that failure is. And usually it's at the anastomosis. So either moving that anastomosis higher up where the vein is bigger, or maybe switching to a different vein, or in the setting where you have interventional radiology, you can use balloon angioplasty to try and what's called balloon-assisted maturation. Then there's the issue of AVF failure just based on thrombosis. That's usually something that happens after the fistula has actually been in use, maybe at a year or 2 years. That failure rate really should be lower than the failure to mature rate. And what I was saying is, an AV fistula can last for years and years and years if you take care of it properly. I've seen patients who've been using their AV fistulas for, 15, 20 years. That's not everybody, most people fall a little bit less than that, but, that is kind of the possibilities. There are other complications that relate to long-term fistula use, like the development of aneurysms, which is super common, and then, other stenoses and things like that. All of those things can be managed surgically. It's just a matter of training and follow-up, diligent patient follow-up.
So I think from our point of view, I think there are a number of things that we've been trying to do. We do have a program where we actually certify nurses to cannulate. I mean, we don't allow new nurses to cannulate. We make sure that they cannulate under supervision of fistulas that are older than a year, the new nurses, under supervision. So until they have finished about 30 or 35 fistulas, then they are actually, evaluated to see, okay, can they independently cannulate? Because I think that's another major issue that we faced. That the new fistulas, the new nurses cannulating, the fistulas would actually have major problems, blow-ups,
Yes. Yes.
and hematomas. So that is something that we do, number one. Number two is, what I've tried recently is in Zambia is, look at the vein where when a patient is admitted to the unit for dialysis, we are going to put in a catheter, but look at the arms and then mark those veins on the hands. And we actually did put plasters that go on both arms on top of the veins. So what happened is when these patients go into the unit with these plasters on their forearm, long plasters on their forearm, the nurses in the ward learn that this should not be cannulated because these are patients for dialysis. So that sort of, sets the whole nursing team in the ward not to use those veins in any patient with CKD, for any other purpose. And so preserve those veins. And that's one thing we do. And so one is teaching the nurses in dialysis, the other is teaching the nurses in the ward. And the third is, of course, important. We have not really reached much there. We teach the patients on maintaining the AV fistulas, but I think we need to do more there. Following on sort of their flows, making sure that they take all the precautions, the exercises that they do with the arms, and so on and so forth. If there's any stenosis, any flow, any anastomotic stenosis and things like that. So that Doppler, regular Dopplers, seeing the flows, that's something we have not done, and we hope that we would actually start off with an vascular access coordinator. So this is all put together. And of course, now we have actually a database that we have put together on our EMR, and that should become active in the next few weeks. So every fistula is captured, and we have data captured with time. And I think that will definitely come by. But in another 6 months, I'm sure we will have a very, very composite data capture that we can analyze to see, okay, how we can improve on various aspects of
Yeah, I totally agree in terms of training that's required for fistula cannulation, which is why I mentioned it's so great that nursing education is really a priority for you guys. I think that's really good.
Thank you very much. And we have a comment in the chat box again from Dr. Huda, who's just highlighted how important it is to preserve, to always consider a radiocephalic AVF as opposed to directly going for a brachiocephalic one.
Yeah, we our preference is to start with radiocephalic as well. A lot of it depends on the size of the veins. So I can't speak to what your surgeons are seeing. I know in the trainings that I've done, I have had to shift my criteria for vein use a little bit lower to use smaller veins than I would normally at home, just because, number one, that's what's available. And I feel like it is still worth a try at a radiocephalic fistula, even if the vein is a bit smaller. However, I would also say that, an incredibly small vein, like a 1 millimeter vein, that to me is not even worth doing. Maybe 2.5 millimeters, I think would be okay. But there is a point at which you're just kind of doing an operation just to do an operation, in which case an upper arm fistula, like I said, is more a better use of time and the patient's time, their patient's catheter time, to just proceed with an upper arm fistula if that's really what their anatomy is going to give you.
And thank you very much. And before we close the webinar out, I would just like to invite Dr. Yuri. He is the Deputy Country Medical Officer. He's in Kenya, actually, and he has been part of such initiatives on the other side of the border. So, I would love to hear from him, his perspective, and the challenges that he's faced.
Thanks, Dr. Amar. Thanks, Dr. Lin. I think Professor Akoko and the team. I think it's quite refreshing and exciting just to see teams that are, going out there to upskill our surgeons just to, to create fistulas for patients, because again, we need to make it more sustainable. I think initially when we started similar pumps in Kenya, and there are a lot of teams that were trained. And again, just to piggyback on Dr. Huda's question, the approach was initially starting radial. I think there was also teaching about going to the snuff box, but we had quite a lot of failures back then. And I think this also made some of the patients in the waiting list now to just backtrack. I think there was a challenge. I have no data to back this, but from what I saw myself in terms of observation, is that mostly the female patients, female cohort of patients, had very high failure rates, especially when the approach was radial as opposed to a brachial. I think maybe, yes, the vessel size was a bit smaller, in certain cases. And maybe, again, there are, of course, patients who are coming in pretty late, you find the vessels have already been damaged by the high uremic toxin load, and probably they're probably experiencing a lot of, I know there's a bit of elastic recoil. It's a bit high also. So maybe there are patient factors, yes, but I think also the approach sometimes depends. So I think we have also seen instances where we are really pushing patients, but they keep referring to other patients that their accesses have failed, or they've had multiple access failures or attempts, and they don't want to go through the same thing. So I think, yes, going back to Dr. Lin's previous comment on patient education, I think it's quite important that we bring the patients along the journey. They understand the importance of having an AV fistula as opposed to catheters, and also just discussing the possibility of failures, the failure rates anyway. Then there's also, on the other side, we've had the national insurance in Kenya, is Social Health Authority, has been reimbursing, on fistulas, but not on catheters. So that was kind of an incentive. But the problem that it posed, again, is that surgeons were just picking all patients, even the ones that are not really good candidates for AVS, because that is what is being paid for. So we end up with a lot of failure rates, and again, it pushes patients away. So I know there's a lot in terms of making it sustainable. Again, to just have buy-in from up top, we need support from the government, from the insurance, from providers in the field, even as we are building capacity. But looking forward to seeing what will happen in Tanzania. Hopeful that we'll get a lot of AVFs, not just with this year, but going forward, again, in the next 5-10 years. Thank you.
Thank you for your comments. I agree with what you're saying. Just because you can do a fistula doesn't mean you should all necessarily. We do need to be thoughtful about what we're doing. It is an operation for these patients. They're paying for it, or maybe they're paying for part of it. It doesn't really matter, but it is an operation on a patient, and it's not, to me, it's not, we shouldn't be doing it if we know it's not going to work. And so again, that's part of why we have really focused on trying to teach the use of ultrasound as well, to evaluate the anatomy before you just make an incision, so you can make an educated incision.
Thank you for that comment, Dr. Lin.
Just to recapitulate on what you just said, Yuri, is I think in my experience, I've worked in HIV clinic as a doctor, but I think dialysis patients bond together more than any other patient group in our local settings. So they speak a lot among themselves. You go to look into the dialysis room and you want to talk to them about every fistula, and they'll be pessimistic if they have a friend who is very close whose fistula did not succeed or has done it one or twice. So I think what we should do with HN support is to have our local criteria that are useful in deciding which patient gets what. I think that's what is lacking. There are other ulterior motives that might drive surgeons or providers to do what they are doing, regardless of vein size. But I think assessing those veins would be very critical. In our experience with 5 or so camps now, I think we have done very few radiocephalic fistulas, because these patients have got so many cannulations, and they're exactly at those same sites. So the veins are really small. But when you go with the principle of starting distally before you go proximally, many do that, and that's where you see lots of failure because they are not mapping. So I think we should have an HN standardized criteria, and that might inform us better in the future and improve our patients' outcome.
I would like to thank everyone for taking time out to be here tonight, especially Prof. Akoko, Dr. Soumya, who took this talk while she is on a bit of a holiday, and obviously Dr. Lin waking up very early in the morning to be here with us. We will have a future chat, I'm sure, on the complications of AV fistulas and aneurysms I think this is just the beginning of a very fruitful partnership as far as these chats go as well. It was a fruitful session, and there's lots of good that can come out of it. So thank you very much for being here tonight.
Thank you very much, everybody.